All right, good afternoon. Welcome to the September IFAM Public Health and Medicine webinar series, which takes place every Thursday at noon. You can visit the IFAM website for more information about the seminar series. We'll place the link in the chat and this presentation will be recorded. My name is Nilay Shah from the Northwestern Department of Preventive Medicine, and I'm pleased to introduce our expert presenter this afternoon, Dr. Milda Saunders. Dr. Saunders is an internist and a health services researcher in the section of general internal medicine in the MacLean Center for Clinical Medical Ethics at the University of Chicago, with research interests in health disparities, quality of care, and understanding how location, such as place of residence and site of care, relates to health outcomes. She's also a clinical ethicist, living donor advocate physician, and the Assistant Dean of Health Equity, Diversity, and Inclusion at the Pritzker School of Medicine at the University of Chicago. We're pleased to have her join us this afternoon to speak about maternal diabetes in neighborhood context. And to our audience, we have two requests. If you have questions, please submit them during the presentation and we'll save them for our discussion to follow. And for questions you may have, we'll ask you to please use the Q&A function on the Zoom webinar screen and not the chat function so we can facilitate the discussion. And with that, Dr. Saunders, I'll turn it to you.
Thank you, Nina. All right, so our objectives today, we have a full agenda to review gestational diabetes and its maternal and child outcomes, to describe both the clinical and the sociodemographic context of Chicago mothers, and to examine how neighborhood economic hardship is associated with race and ethnicity disparities in maternal diabetes and poor perinatal outcomes. And then finally, and I hope this is where we have a robust discussion, to explore both public health and public policy options to reduce both these disparities in maternal diabetes and the negative health consequences for both mothers and their children. Gestational diabetes is defined as impaired glucose tolerance that has its first onset or recognition during pregnancy. And it accounts for about present in about 2 to 10% of pregnancies. And leads to a whole host of negative outcomes, both during the pregnancy for both mother and fetus, and then after or during delivery, which leads to more intervention during labor and increased neonatal complications. And the interesting part, and sort of what brings me to this work, and many of you others, I would imagine, are some of the longer term consequences that we see. So women who have gestational diabetes are more likely to have gestational diabetes in subsequent pregnancies, and also are more likely to have type 2 diabetes either soon after or later in life. And interestingly, perhaps discouragingly, the infants born to these mothers grow up and have an increased risk for obesity, for type 1 and type 2 diabetes, and metabolic syndrome. And increased risk for cardiovascular events. So we want to find out what are the risk factors that lead to this so that we can intervene. And as we think about risk factors for maternal diabetes and for infant outcomes, we start with the biological factors and personal factors related to the individual. And that may be individual history as well as family genetics, demographics, older age. But then as we move further down the ladder, we see that things are more influenced by social determinants of health. So lifestyle, diet, community, exercise, socioeconomic factors, which are all interrelated to where people live and what they are able to do and are exposed to. And then we move sort of further down to things that perhaps are more within the realm of the healthcare system. So access, utilization, and then what happens in the medical encounter. So provider bias or provider-patient miscommunication, to be generous. And when we look at health disparities, we see a very similar ladder. Health disparities defined as the difference in either the quality of care or health outcomes between a non-minoritized and a minoritized group. And we see that there are, in some disease processes, biological differences or difference in risk based on genes or gene-environment interaction. There can also be differences in clinical appropriateness and need or patient preferences. Now, I would argue that that is sometimes really determined by education and how patients have things explained or taught or are able to understand. So that's sort of a perhaps in the realm of disparities. But as we move to disparities, we see these broader societal discrimination, prejudice, and economic injustice. And so that's where neighborhood lies. And then we move into the healthcare system. So both who is able to come to the door, the regulatory climate, who has insurance, and where that insurance is accepted, and then what happens within the clinical encounter. So those lead to healthcare disparities. And so thinking about this as we work together for some clinical and policy solutions. So looking for prior work on health disparities in maternal diabetes, most recent paper for Dr. Shah and others here looking at birth records has shown that the overall rates of gestational diabetes have increased over time, and that the rates among minoritized groups vary tremendously. And what is perhaps surprising for some and not for others who are more deeply in this field, in that it's not our usual suspects. And so we see that Asian Pacific Islanders have the highest rates of gestational diabetes, followed by Hispanic, Latinx, and then African American and Blacks are slightly lower than non-Hispanic whites, which were the referent group. And when we look at Asian Indians, we see that it's even higher than the Asian Pacific Islander group. However, Black women were more likely to have pre-existing pre-gestational diabetes. And when we look at what that means clinically for outcomes, we still see that minoritized women in one systematic review, non-Hispanic Black women, Latinx women, and Asian women had significant higher risk of negative outcomes, including preeclampsia, preterm birth, and readmission. And in an earlier study, Black women were shown to have higher odds of preeclampsia and preterm delivery. And so they're two separate but related things that we want to examine, both who gets diabetes and how that leads to negative clinical outcomes. So our prior work with the CDPH and researchers at University of Chicago looked at the change both in gestational diabetes and pre-existing diabetes over time. So we were fortunate to have access to birth data that separated the two and wanted to be able to isolate because as you see in national work, there really are different groups that are impacted by one versus the other. And so we can see, looking at rates of gestational diabetes, it has in fact increased over time for all comers. However, it is most significantly increased for Mexican mothers and followed by non-Hispanic Asian mothers. And when we look at age-adjusted rates of pre-existing diabetes, we see that while Black women, as in national literature, have higher rates of pre-existing diabetes, in our Chicago cohort, Mexican mothers had both the highest rate overall and a large increase in pre-existing diabetes. So something similar to national trends, but sort of some unique outcomes for our area. And so we wanted to understand why. One interesting, challenging thing about Chicago is we have a large amount of both residential and economic segregation. And so we wanted to see if neighborhood economic hardship was associated with these racial and ethnic disparities in maternal diabetes and poor perinatal outcomes. So we looked to see both odds of diabetes as well as odds of C-section and preterm birth, the most common negative outcomes. So we use Chicago birth data between 2010 and 2017, and also used neighborhood economic hardship, which is based on 6 factors from the American Community Survey, which are crowded housing, percent below poverty, percent of working age who are unemployed, adults who have greater than a high school education, dependency, those under 18 or over 65, as well as income. And then for some of the birth outcomes, we looked at hospital perinatal levels of care to see how that influenced outcome. And our dependent variables were gestational diabetes or pre-existing diabetes analyzed separately, and then looked at a stratification for both race, ethnicity, and neighborhood hardship level using multivariable regression. We can talk more about this later. So as you look at a map of Chicago, we see that poverty or hardship is not random. It is concentrated in the South and in the West. And if we were to overlay a map of individuals in minoritized, from a minoritized group, we would see that the maps look very similar. So when we, again, are dependent and independent variables, so we started with over 300,000 women who had given birth over the time of interest. And after we dropped variables for missing for hardship or diabetes information, as well as mothers who had either not had a singleton birth or were sort of on the extremes of maternal age, or we weren't able to classify race, we were left with slightly under 300,000. And just so we can discuss all of the things that we controlled for or adjusted for: maternal age, education, marital status, foreign-born status, smoking, insurance type, number of live births, which we excluded, hypertension before and during pregnancy, and perinatal care measures. And then our birth outcomes looked at hospital perinatal care level, and then prior outcomes. So this is a lot of data as we divided, and so we'll go through each group separately. I do not expect you to be able to process this. This is sort of a really rich look at Chicago mothers. So as we look at white mothers over time, we see that overall, about 13% of white mothers were diagnosed with gestational diabetes. And the majority, the vast majority, over 3/4, lived in low hardship neighborhoods. But we also see, not surprisingly, that as the economic hardship level increased, the educational attainment decreased, the age of mother and the proportion of non-married mothers increased, as well as government funding for insurance. And so this will be a consistent trend as we go across all of our data. As we look at Black mothers, we see that about 10% were diagnosed with gestational diabetes. But as we talk about sort of the differences, we can see that only about 12% of Black mothers during this time period lived in low hardship neighborhoods. And when we look at women who lived in low hardship neighborhoods, we still see, compared to white mothers, lower overall educational attainment, higher proportion with public insurance, and lower proportion with married status. And we included both married and domestic partnerships. And similarly, as economic hardship increased, neighborhood economic hardship increased, we saw that individual disadvantage increased, reduction in education level, and the age of mother, and the increase in single motherhood and public insurance. We see that overall about 23% of Asian mothers had gestational diabetes, and about 59% lived in low hardship neighborhoods. So, definitely a difference compared to both white, lower, and Black mothers. And similarly, all of the things that we think of as individual disadvantage or potentially leading to individual disadvantage, education, age, single motherhood, and government insurance increased as we go to increased hardship neighborhoods. Mexican American mothers, interestingly, we see 20% were diagnosed with gestational diabetes. And this is the most striking. 16% of Mexican American mothers lived in low hardship neighborhoods. Only a quarter lived in medium hardship neighborhoods. And so the vast majority of Mexican mothers lived in high hardship neighborhoods. And overall, as a group, had lower attainment and private insurance, and that disadvantage increased as you go to greater disadvantaged neighborhoods. 16% of other Hispanic mothers were just diagnosed with gestational diabetes, and this group so we separated them because we think the groups are different. And when we look at the demographics, we see that that's true. 38% of these mothers lived in low hardship neighborhoods, and only 37% lived in the higher hardship neighborhoods. And similar trend of economic hardship across neighborhood disadvantage. So going to our results. So we'll go, this is again, a lot of data, so we can go through slowly. So we used white women in low hardship neighborhoods as the reference group. And we can see that as you move in any direction, things get worse. So the odds of having gestational diabetes increase. So for white women, as you go from a low to a medium hardship neighborhood, the odds of having gestational diabetes is a 0.6 greater odds of having gestational diabetes compared to the low hardship neighborhood. We don't see this stepwise increase as you go from medium to high. You'd say, they're roughly the same. And in fact, the point estimate and the confidence interval actually looks a little lower in high hardship neighborhoods. Similarly, as you go, if you look within low hardship neighborhoods across other racial ethnic groups, you also see an increase in odds of gestational diabetes diagnosis. So African Americans have a 1.4 greater odds, Mexican Americans 2.1, Asians 2.4 roughly, and other Hispanic 1.7. And then as you go across neighborhood hardship within ethnic group, you see that there is not necessarily the prior relationship between neighborhood hardship and odds of gestational diabetes. So for Black women, while the point estimate is actually lower as you go from medium to high neighborhoods, the confidence intervals are such that we don't necessarily say there's a difference between medium and high. Although we do see that Black women who live in low hardship neighborhoods actually have a statistically significant difference in odds of gestational diabetes compared to women in high hardship neighborhoods. Not to say that living in a high hardship neighborhood is overall good. However, in the discussion, we'll sort of talk about some reasons why that might be the case. Similarly, we see for Mexican American mothers, while the overall odds of gestational diabetes is higher, we don't see a stepwise increase as we go across neighborhood disadvantage. For Asian mothers, the odds is again high, but we don't see the stepwise decrease. And in fact, we see sort of a higher point estimate for medium disadvantaged neighborhoods and a lower estimate as we go to the high disadvantaged neighborhoods. So sort of thinking about what that means. And then similarly for other Hispanic mothers, we again don't see a significant change across neighborhood disadvantage levels. So a variation in how both race and neighborhood disadvantage interact to produce gestational diabetes outcomes. All right, and so this is a different look at pre-existing diabetes. So again, same format, same analysis. We looked at white women in a low hardship neighborhood as the referent group. And as we move across within a racial group, we see that moving from a medium hardship neighborhood to a high hardship neighborhood, controlling for all of the factors that we talked about before, there is an increase in odds of just pre-existing diabetes. For Black women, similar to our national data, we see that there is a high rate of gestational pre-existing diabetes, and that it is not increasing as you go across neighborhood disadvantage. For Mexican women, there is a high rate of pre-existing diabetes compared, or higher odds of pre-existing diabetes compared to their white counterparts. And it remains high all across neighborhood strata. So, and then for Asian and Hispanic women, they both have a higher odds compared to the referent group. And we don't see significant differences for other Hispanic women as you go across neighborhood strata. For Asian women, again, like their Mexican counterparts, we see sort of a bump in odds of pre-existing diabetes as you go from low to medium, but we don't see the same point estimate, although pretty wide confidence intervals for Asian women in high neighborhood disadvantage. All right, a lot of data. And so we wanted to also look to see, did these within group, did these rates of gestational diabetes or pre-existing diabetes translate to poor outcomes? And so when we look at, okay, so this looks at, a lot of slides look the same. So when we look at preterm birth, which was the first negative outcome we wanted to look at, we see that similarly for our reference group, we don't see the same relationships that we saw before. So for white women, as you go across neighborhood disadvantage, there is not, one, they're pretty wide confidence intervals, and we don't see really a significant difference in preterm birth. As you look across down each column, so for women in low disadvantaged neighborhoods, we see that Black women, Asian women, and non-Hispanic, other Hispanic women have higher odds of having preterm birth with gestational diabetes and in low disadvantaged neighborhoods. So there is this different effect for this neighborhood advantage, even after we controlled for many of the individual, both socioeconomic and clinical characteristics that I described earlier. And as we go to medium income neighborhoods, we see something similar in that Black, Mexican, and Asian women have higher odds of preterm birth. And then in high neighborhoods, high disadvantaged neighborhoods, we see it sort of skips around. Black women are consistently having higher rates, higher odds of preterm birth, but Mexican American mothers, as well as other Hispanic mothers, also have higher odds of preterm birth with gestational diabetes. As we look across column to look within a racial ethnic group across neighborhood disadvantage, we see a similar picture as we had seen in some neighborhoods, some of our prior analyses. So for Black women, it is the impact of race and all that comes with that, rather than neighborhood hardship that is associated with the greater odds, because there is not really a significant difference in odds of preterm birth for mothers with gestational diabetes across neighborhood economic hardship. So the point estimates are the same and the confidence intervals overlap. For Mexican mothers, we see that there are pretty wide confidence intervals for the low hardship neighborhoods, both because it's a unusual outcome or less common outcome, and fewer Mexican mothers live in low hardship neighborhoods, as we saw earlier. However, we still see that there's a greater odds for preterm birth in the middle income neighborhoods rather than the higher income neighborhoods, although there is some overlap of the confidence intervals. And then for Asian mothers, there is certainly an increased odds of preterm birth compared to white women. However, similar to what we saw for Black women, neighborhood economic hardship doesn't change that relationship. And in fact, the point estimate for Asian women in high hardship neighborhoods is lower. However, we have pretty wide confidence intervals. So I'd call it about the same. And for other Hispanic women, we see that there are, it's a sort of difficult story to tell. So we see that there is a higher rate compared to white women in lower hardship neighborhoods. And there is a lower point estimate, but a pretty wide confidence interval. So perhaps no difference. And then again, a higher point estimate and some suggestion that there is a higher rate of preterm births for women with gestational diabetes in higher neighborhood economic hardship neighborhoods. All right, so when we look at preterm birth, we go through a similar analysis and story, except this is sort of easier to process because we don't really see that there is much of a difference in preterm birth for women who have pre-existing diabetes across race or across neighborhood economic hardship. In part because the confidence intervals are really wide. We're sort of looking at an outcome that is not as common. And as we get into the different neighborhood types, they're sort of the cells get smaller. And so we're not able to sort of with confidence make significant statements about difference, with two exceptions, probably both because of the magnitude of the difference and because of the proportion of women who are in high disadvantaged neighborhoods. We see that Black women with pre-existing diabetes in high disadvantaged neighborhoods have a higher likelihood of preterm birth. And similarly, we see that Asian women in middle hardship neighborhoods have a higher likelihood of preterm birth, which we think is both because there are more women represented in those columns and perhaps a greater difference. All right, so we move to C-section, another negative birth outcome. And we see that there is not as much of a difference as we look both across neighborhood context and across race within neighborhood category, with Black women being the exception in that while there is not this significant neighborhood effect, because we don't see a significant difference between Black women, the point estimate or the confidence interval across neighborhood category, we do see that Black women compared to white women and all other racial ethnic groups have a higher C-section rate that is influenced by neighborhood. All right, and then pre-existing diabetes, bear with me. So before we were looking at gestational diabetes, and then now we're looking at pre-existing diabetes for C-section. And similarly to preterm birth, We don't see a significant difference, in part because the cells get really small. And so we see some suggestion, but we have pretty wide confidence intervals. All right. So we saw that Mexican-American mothers were less likely, Mexican-American, African-American mothers were less likely to live in these low hardship neighborhoods, but even within these neighborhoods have a greater disadvantage. We also saw that there was an overall increase in gestational diabetes in mothers over time, and in pre-existing diabetes in Mexican-American mothers, and that the odds of being diagnosed with gestational diabetes is higher amongst mothers of all race and ethnicity compared to white mothers in our reference group, regardless of hardship status. And it is, in some cases, we saw that overall it's higher in medium hardship neighborhoods, although in high hardship neighborhoods, it was highest amongst Mexican-American and other Hispanic mothers. When we look at the perinatal outcomes, we saw that the odds of a mother with gestational diabetes, so that particular group having preterm birth, is higher amongst Black American, Mexican, and Asian other mothers compared to white mothers, regardless of neighborhood economic status. However, Black mothers living in areas of hard economic hardship are more likely to have preterm births, and that Black women with gestational diabetes had higher rates of preterm birth across all neighborhood types. And that overall, we saw that the odds of having a C-section are highest in Black mothers with gestational diabetes, again, across all neighborhood types. So when we think about the clinical implications, you know, I'm an internist, I'm not OBGYN, and so I don't see women who are in their latter pregnancy, nor who are diagnosed with gestational diabetes. So from a public health and from a generalist and even a subspecialist focus, the focus should be sort of focusing more on at-risk women prior to pregnancy to reduce risk factors. And one possibility would be sort of culturally specific interventions that focus on lifestyle changes and both gestational diabetes education and maintenance, both to reduce likelihood of having gestational diabetes, and once women do have gestational diabetes, sort of reducing the negative effects of gestational diabetes by having better control. Also, we saw that some of the rates don't seem to be associated with the prevalence of gestational diabetes or pre-existing diabetes, but are more related to the individual racial ethnic group. And so some of this may not be sort of a cultural thing, but maybe a health services thing. And so we can increase referral to high-risk OB and to higher level of care hospitals for patients with diabetes to hopefully, again, reduce and manage complications so that we can reduce sort of these negative birth outcomes. And then also think about what is happening both at the patient, provider, and the health system level that account for these high C-section rates among Black women and higher rates of preterm birth. And so policy implications, and again, we'll welcome discussion. So we certainly want interventions to target racial and ethnic disparities to improve communication, improve quality of care, and to promote health equity for pregnant women with diabetes and their offspring. So saying that this is a point of interest, and both having policies and funds to support those policies so that we can both prevent these short-term outcomes that I showed, but sort of the longer-term outcomes, both for the women and their children. And part of that can be including an expansion of the safety net, both overall, because we talked about some of these risk factors occur prior to pregnancy or maybe early in pregnancy, but particularly during pregnancy. And some of this may be increasing both prayer rates and incentivizing some of these higher level of care hospitals to accept Medicaid so that women who have a greater need have access to greater care. One thing I didn't show is that some of the white women in these lower economic hardship neighborhoods were more likely to deliver at hospitals that provided a higher level of care. And then we also want to increase access to and education about contraception so that women are able to manage their preconception health. And then, of course, reducing both structural and interpersonal racism. So there's a reduction in maternal stress and an overall improved access to opportunity. All right, and I want to thank my many collaborators at the Chicago Department of Public Health who both helped explain the data, helped us access the data, and worked hard to, so that the CDPH interns could have space in the building and access during the pandemic to the interns who both worked at University of Chicago and trekked back and forth to CDPH, and then to colleagues and collaborators within medicine, including Julia Caldwell, who is now in the Los Angeles Department of Public Health, and Arnika Lewis, who's at Duke. All right, and then any questions, comments?
Dr. Saunders, thank you so much for that really illuminating and important conversation about maternal health, especially locally. We have several questions that have come up that I'll pose, but first I'll actually see if Dr. Ackerman is available to ask the question that he posed. I know he has to depart shortly.
Okay.
Yeah, thank you so much. Hi, everybody. And thank you, Milda, so much for presenting. That was really an outstanding presentation of a really important area of health disparities. And no disrespect, the reason I have to tune out is because actually it's the kickoff meeting for a new national center that we have that we co-administer with the University of Chicago on diabetes, on health. Yeah, it's on health equity and health disparities and diabetes in the city of Chicago. So it's very thematically oriented to your talk. So I just, one question I had is my understanding of, and I'm also a general internist, so I not an expert in GDM, but my understanding of classifying gestational diabetes is that once you have pre-existing diabetes, you no longer are classified as gestational if your blood sugar is high during pregnancy, because so when you break the analysis apart into those two different subgroups, you're sort of splitting down the middle a group of people that is at high risk for preterm birth and C-section and some of those bad outcomes because their glucose is high during their pregnancy. And in groups that you showed that in some cases there's an increasing prevalence of pre-existing diabetes, it makes it less likely that people will have GDM in those same neighborhoods because there's more people that already have established diabetes. So my question is, if you had actually pooled those two together, do you think you would have seen a more consistent gradient that instead of in some of those analyses where the medium vulnerability communities seem to have the worst outcomes or the highest prevalence, where if you pooled them of total dysglycemia maybe in those different groups, you might see a more consistent relationship as the community is becoming more vulnerable and affected by social and structural determinants of health, that you would see a higher risk of those bad outcomes consistently with more vulnerable communities.
Yeah, and so that's a good question. One, I don't know that it would change our outcomes, because even though we saw that the rates are increasing of pre-existing diabetes, the rates overall were relatively small, even for women who had higher rates. So they were less than, even in our high groups, which were African-American and Mexican-American women, they were less than 1%. So don't necessarily think that it would change. Now, what may change is some of the perinatal outcomes, because they were really small anyway. And so even a couple additional cases would overweight those outcomes. But one of the reasons that we wanted to do this analysis is that we thought it was important to look at the women differently, because it is a different set of women. And we might, we don't want to always, a lot of the work focuses on the challenges faced by African-American women. And I think that's true. And I think that there are true and we should, but we also don't want to miss people, racial ethnic groups or communities that also need an intervention. And so I think if we focus, we say we only want to focus in one neighborhood versus another or one group versus another, then we're not actually providing care to all of the groups who might benefit.
Great, thank you. Another question comes in from Dr. Jeffrey Linder, who thanks you for your excellent presentation and asks if you can talk about how the detection and documentation of gestational diabetes might differ between racial and ethnic groups and among neighborhood hardship status.
Yes, so that is hard. So this is administrative data. And so it is lovely to work with, but it's messy. So I would argue that if there was a differential reporting, it would actually then understate our results so that a lot of women who were in more disadvantaged neighborhoods and more disadvantaged hospitals would probably be more likely to have birth records that were incomplete and not appropriately filled out. So that certainly is a possibility, but I think it would actually, having sort of complete data might strengthen our results rather than weaken them. And then in terms of surveillance, you know, I'm not a GYN, but I think that it is for women with prenatal care. It is so consistent that women are screened for gestational diabetes that I think it is unlikely that it would be missed clinically for people who are actually presenting to care. But I think your point about documentation is a good one. We did find that documentation about WIC was so not reliable that we chose not to use it. We on both sides, women who probably had WIC, it wasn't recorded, and women who didn't use WIC were sort of incorrectly coded. And so there is some evidence of that. And so for that, we just actually weren't able to use that data.
Yeah, that makes a lot of sense. And in fact, I certainly agree with that. In some of the surveillance work that I have looked at, these vital statistics data actually are collected pretty reliably by clinicians. And so in women who are delivering in a clinical setting, those vital statistics records, just as you say, I think can be pretty reliable. We have a question from audience member Soletta Nichols, who asks, we hear a lot about African-American women dying in childbirth at higher rates than other ethnic groups. Is gestational diabetes or any of these other APOs a contributing factor for this phenomenon, and to what extent?
Yeah, and so it is, yes, and that is not the only factor. So we think that it is both clinical and we think it's at the health system level. And so there are documented cases, both sort of anecdotal and sort of in larger studies, about Black women having sort of negative outcomes and having negative sort of provider clinician experiences. And so I think it's not just, you know, when I talk about this work, we sort of use race as a social construct, not as this biological reason why people are having these negative outcomes. And so I, you know, in all of these studies, we sort of want to think about what is it about Blackness or about being a Black woman that would lead to these negative outcomes. And I don't think it's, you know, there may be some biological factors, but I don't think it's just biological. I think it's sort of the health care system where people get care and also the care that they receive when they walk through the door. And so those are perhaps the easiest ways that we can make a change, because those are the things that are within our control.
Absolutely. And I think, I hope, and I think that there's an increasing recognition that, just as you said, race as a social construct is representative of differences in a lot of other factors, and generally speaking, is not really, should not be inferred to be a biological underpinning to differences. A question from an audience member, Precious Walker, who asks, how will you use these data in preventive medicine? And I am going to build on that because I think it's an excellent question, which is just in your experience and in your work, how do you think we might best identify women who are at risk for adverse pregnancy outcomes pre-pregnancy, like gestational diabetes or preterm birth. Now, your data suggests that we should be accounting for things like socioeconomic position and at least recognizing that there are differences between people of different race and ethnic groups.
Yes, and so I think not only should we recognize it, but sort of talk about, I think one of the things that we sometimes see is that many pregnancies are certainly wanted, but surprises. And so rather than thinking about what happens after a woman gets pregnant, I think we should be thinking about how can we optimize health for young women so that if they get pregnant, they are in good health. And for women who are not interested in becoming pregnant, how can we make sure that that doesn't happen so that they can so that they can manage their health in the way that they want. And so I think that those are some ways that we can work there. But I also think that maybe thinking about, it's hard to sort of think about risk factors and then when you come into the clinical setting, you don't want to sort of make someone just their epidemiology. And so I think making sure that we talk to people about how do they eat? How do they exercise? What are their stresses? So that we are thinking of them as this group, but sort of asking everyone individual questions. And I also think that there are, what we saw in the data is that there's stresses, regardless of where you are. They may be different, but they're present. And so if you live in a middle income neighborhood, there may be different stressors, but they still have a clinical outcome or a clinical impact. And so just asking about stress rather than thinking that we know where they live, we know how they are dressed and how they talk, we know about their life.
Excellent, thank you. Another question from an audience member, Tobias Holden, asks, at what level is neighborhood economic hardship determined? Is it the level of the census tract at the neighborhood community area? And how do you think findings might change at different kind of spatial resolution of neighborhoods and economic hardship?
Yes, so Chicago CDPH looks in the community area, and it might change. And with neighborhood work, it really is hard to figure out the right level. And I would argue that it probably varies based on what you're looking at. And in this case, the community area is probably the right one because we're not looking at something that's happening on your block. We're sort of looking at, one of the good things about community areas is that there's sort of these, not an artificial construct, there's sort of these natural areas that have meaning. And so it is more likely to reflect people's sort of lived experience than we do see perhaps with a census block group, which may be too small, or a zip code, which may be too large and heterogeneous.
Great, thank you. Another question from an audience member. There is a recognition that many pregnant people do not identify as women, and it's important to see this reflected in our research. How do you see this field at the institutional level, changing language and research to include transgender men or non-binary people in this work?
Yes, so it is, yes, it is hard when talking about maternal outcomes to change language. And so my apologies, I'm still learning. I think we're all sort of learning to be more inclusive in language. And I think sometimes thinking about deliveries sort of triggers things that are perhaps more regressive than they should be. And so I do think that using the appropriate language is important, both to reflect reality and then also so that we can destigmatize care, because people who are not pregnant people who don't feel welcome into the healthcare setting are more likely to have negative outcomes. So thank you for that reminder and correction.
one question that I'm going to pose, because I think it's really interesting in this work, especially as we think about the implications of the findings you have found and reported, is that, I think there's growing recognition that health during pregnancy affects not only that person's health and trajectory to later through their life, but also that of their offspring. And so it's a little bit of a comment, but also just kind of a question, thinking more broadly, especially about potential policy implications about how we think about interventions at multiple levels: individual, health system, community, population, policy. Because I worry that the trends that we are observing and the trends we reported portend this kind of growing burden of disease more broadly, and poor outcomes more broadly, I should say, in individuals who are pregnant and experience these pregnancy outcomes, as well as their offspring.
So I think that's right. I think because our health system is so choppy, we don't necessarily take the long view. I think in systems that have sort of a single payer system, there is more of an emphasis on prevention because the healthcare system will be paying down the road, and we don't necessarily have that view. I think the second thing is sometimes a lot of the, I think CDPH talks about health in all policies. A lot of the policies that are probably most impactful may not be health related within either the auspices of the medical system or the auspices of the departments of public health. And so I think that is also sometimes, even if we know the right thing to do, we're sort of thinking about, well, who will pay for it? And so I think that's a sort of a challenge in where the pots of money come.
Indeed, indeed. A question that I think I am interpreting correctly, so I apologize to the audience member if I've misinterpreted, but did your accounting for neighborhood economic hardship account for the racial composition of neighborhoods as well, or was this controlled in the analysis?
No, so we did not account for neighborhood racial composition in the analysis. That's not a part of the hardship calculation. I have looked at, in other analyses not related to maternal diabetes, to look not at the sort of complex index of neighborhood hardship, but to sort of look at race and poverty. And as not surprisingly, there is a difference. I mean, neighborhoods are different based on their racial composition, even controlling for the neighborhood economic hardship or neighborhood poverty. For this, I thought for some things we'd just be splitting the neighborhood, or we'd be splitting our boxes in too fine a cut. And also one of the things that we know is that other than African Americans, who tend to be the most segregated racial ethnic group, other people have the experience of living in more racially heterogeneous neighborhoods. And so it would be sort of harder to make those different slices.
Yeah, indeed. Great. I have one last question that I'll pose, which is a question from me, and it's actually for my education because we have your expertise, and I appreciate that. I don't know if there's a right answer to this question or a definitive answer, but I kind of wonder. Tough, huh? I kind of wonder. When we think about differences by race and ethnic group in some of these measures that you have presented, these outcomes that you've presented, we talk a lot about potential cultural differences or behavioral or lifestyle differences, which I think is correct. What, in your kind of experience or understanding, do you think it is about economic hardship that leads to some of these differences? Do you think it's more about access to care? Do you think it's more about income? Do you think it's more about literacy and education? It probably is a combination, honestly, of all of these things. And it may differ by neighborhoods, but do you see patterns in terms of the different aspects of economic hardship that may contribute to some of these observed differences and associations?
Yeah, I think it varies, but I think it is you know, one of the, I like to think about when you go to look for an apartment or a home, the things that you just instinctively know are important, right? You look at, are there clean streets? Is there a grocery store? Is there a drugstore? Do you feel safe? Can you walk at night? Are there services around? Is there green space? Is it quiet? And so, because all of those things sort of overall add to your physical and mental well-being. And so if you think about a neighborhood that does not have those things, there are not sidewalks that are smooth. And so if you have limited mobility, you cannot, you know, use them. There are not grocery stores that have produce that is either available or is fresh. There are parks perhaps, but you don't feel safe walking after you get off work because it's dark. You don't want to take the bus because you don't want to walk to the bus stop. So all of these things that we sort of just instinctively know and look at as a gestalt about this is a good neighborhood because they impact our health and well-being. There are many disadvantaged neighborhoods that do not have those same resources. You know, and just one example, as we think about drugstores, we know that in some disadvantaged neighborhoods, they are just starting to have drugstores reopen. And so can you imagine the adherence and challenges that you would have in sort of managing a chronic disease if you don't have your local drugstore? And so that's just sort of one small thing multiplied by many things. And then also you don't necessarily see people walking around, or you don't see people doing X, Y, and Z. So it's not just the resources, it's also sort of your peer group and what you think is sort of normal and appropriate, and lack of information. So if you talk to someone and say, oh, have you ever had this? What should you do? You may get good advice, you may get less knowledgeable advice. And so it's this whole range of things, as well as these external stressors. One small example, outside of my home, they're doing construction, they're having a new bridge. It is so loud, it is very disturbing. And so if I faced, you know, that same noise every night for months and months, I'm sure there would be some negative health outcome. And so there are just sort of multiple things that sort of add up over time.
Yeah, that's very insightful. Thank you. Well, Dr. Saunders, thank you so much. I think we're just about out of time. This was really an outstanding presentation and sharing your expertise and work. I appreciate your joining us this afternoon. And to our audience, look forward to more notifications about our subsequent seminars.
Thank you for inviting me. Thanks for your time.